And I think it's a very interesting topic that I've been asked to present about today, is the evolving role of intravascular ultrasound in minimizing use of contrast, especially in patients with borderline or threatened renal function, so that we can avoid renal complications. I will use two illustrative cases to drive home the message in this particular topic. My first case is a 54-year-old male who presented with symptoms of LVF, and he was a known CKD, though he was never dialyzed. He was hypertensive and diabetic, and the ECG showed an evolved inferior wall infarction. And the angiogram showed that there is a moderate to severe stenosis in the proximal right coronary artery, and he also had a long tubular lesion in the mid-LAD. So the RCA was engaged with 6 French Judkins right catheter, a guiding catheter. Lesion was crossed with a run-through, and the IVUS was done. And the IVUS showed a fatty plaque with a lot of lipid burden and with the presence of a thrombus. And after pre-dilatation, a long stent 4 into 33 DES was implanted and was post-dilated with a 4.5 non-compliant balloon. And this is the final angiogram, and which showed TB3 flow and a good result. And the final IVUS pictures also showed a nice MSA. The case 2 is a 74-year-old man who presented with recurrent episodes of rest angina with dynamic EKG changes. He had an eGFR of 40. He was a diabetic and a hypertensive. Though the echocardiogram was normal, he didn't have a resting regional wall motion abnormality. An angio was done which showed triple vessel disease, and he was given the options of a CABG as well as a staged PCI. And this is the angiogram. The angiogram shows diffuse long segment disease of the LAD with a very critical block in the mid segment. And you can also see that even angiographically there is significant calcium in the lesion. The RCA was non-dominant and small. During the course of the hospital after the angiogram, the patient's creatinine started increasing, and a nephrology consultation was taken. Despite optimal management, his creatinine levels were rising steadily. So the PCI was deferred and the patient was discharged with medical management. But he was readmitted through the emergency room with LVF, and he had chest pain on the night, on the previous night. Though his troponin was negative, he had dynamic EKG changes. He was stabilized, and his creatinine was around 3.3 to 3.5. So, in view of his unstable coronary symptoms, and in the view of the rising creatinine, he was offered the option of an IVUS-guided minimal contrast or a no contrast PCI. And the interesting challenge in this particular case is that it's a calcified lesion, and he would need a rotablation. So it would be a minimal contrast or a zero contrast PCI with rotablation. So because the lesion, the mid-segment lesion was very critical, it was pre-dilated. It's a very delicate conservative pre-dilatation was done with a 2 millimeter balloon. And then the IVUS was done, and the IVUS showed a significant more than 270 degrees thick, diffusely calcified lesion, more than 10 millimeter in length. So it was decided that we should do a rotablation for this case and a 1.5 bar at 160,000 RPM. And there was a significant drop of more than 10 RPM when it was traversing the critical lesion. And after the rotablation, a repeat IVUS was done. It showed that there were significant cracks, multiple cracks in the calcium. And then a proper assessment of the vessel size was made, and the pre-dilatation with a 2.5 and 2.75 non-compliant balloons were done, followed by a scoring balloon of 3 into 10 millimeters. Then post this coating balloon, again an IVUS was done, and we could see that we achieved a significant lumen gain, and with multiple cracks in the calcium. So the vessel bed was adequately prepared, and we seem to be ready for stent implantation. So basically, in this particular, at this step, we mark the distal landing zone and the proximal landing zone by the position of the radio-opaque marker on the IVUS catheter. And these will serve as landmarks for us for the final stent implantation. And then we fix the table and fix the view, and we go ahead and do the stent implantation in this particular view. So it was decided that it's a long lesion and required two stents. Mid-LAD was stented with 3x33 DES and post-dilated with 3x12 non-compliant balloon. And a proximal 3.5 × 15 millimeter DES was taken. However, during stent inflation, because of the calcium, there was a proximal pushback of the stent, and the stent got implanted right from the ostium of the LAD. So we obviously had a small area of geographic miss. And it was checked on IVUS examination, and there was a small area of 4 to 5 millimeter area of geographical miss between both the stents. So these stents seem to be reasonably well deployed, reasonably well opposed, and expanded well. And so the geographical miss of about 4 millimeters between the proximal and distal stent was covered with a third stent. It's a 3.5 × 8 DES deployed, overlapping both the stents. And ostial stent proximal portion was optimized with a 4 × 6 non-compliant balloon. And this is the final HDI was run, and it shows all the three stents are well expanded, well opposed, with very good minimal stent area, and looks like an optimal result. So to cut the long story short, it was we had a proximal MSA of 11.2, mid MSA of 8.9, and distal of 7 millimeters squared. And there was no edge dissection, there was no malapposition, and it was well expanded. So we did a final contrast shoot we did two final contrast shoot, one in the caudal and one in the cranial view. Only 6 ml contrast was used during the entire procedure. And post-procedure serum creatinine levels decreased, and patient was discharged in good condition. So this is the final angio. This is the reference, this is the baseline, and this is the final angio. And this is again the final result. So what is the need for minimal contrast PCI? We all know that CIN is an important problem in patients with borderline or compromised renal function when we do therapeutic interventions. And the incidence is quite high, and there are several risk factors, including old age and heart failure, and the most important thing is the volume of contrast injected. So this is for the benefit of young cardiologists. This is the Mehran score that we typically use to predict the risk of renal failure post-intervention. And thereby we have the role of intravascular ultrasound to help us in minimal contrast or zero contrast PCI. It helps us in lesion recognition, characterization, and stent implantation. And where the proximal landing zone of the stent and the distal landing zone of the stent, and also to obtain an optimal result. So how do we do step by step is we need a pre-procedure planning and preparation. We need to hydrate the patient, and I typically engage the catheter without contrast administration. One little help is that we can inject a small amount of saline once we engage the catheter. If you're engaged, you can see T-wave inversions on the ECG. That shows that the catheter has been engaged. And then, if possible, the angiography should be done a few days before, and limiting the contrast to medium. And then we need to have that as reference when we're doing the procedure. Thereby, we don't need to do repeated shoots. And there are several techniques of procedure navigation. We can have anatomical landmarks, especially with the presence of calcification, and we can use the IVUS guidance. We can have a marking wire technique, which we can put a second wire as a marking wire, which will serve as a hard landmark. We can also have side branches on the IVUS as a soft landmark. We can create a metallic silhouette of the segment of interest by positioning wires in the proximal and distal side branches. And to begin with, we pass the wire across the lesion, and we can have supplementary guide wires to serve as hard landmarks. And this is how we can create a metallic silhouette. We know that by putting a wire in the first OM branch, we know where is the proximal landing zone. And this also helps in most situations. So another technique is to have a marker guide wire in this fashion. You can put a marker guide wire, and then that is left in place till the point of stent implantation. And the IVUS probe, we can use the radiopaque markers of the IVUS probe, and we can actually save the fluoro to decide the distal landing zone and the proximal landing zone. And by freezing the table, by not changing the position of the table and the image, we can position the stents precisely. So the algorithm is that once we put in the guide wire, we can have a metallic silhouette, or we can use an IVUS catheter used marking, or we can use a marking wire technique. Then we do the IVUS pullback, we do the stenting, and we do a post-stenting IVUS pullback to make sure that the result is optimized. So, of course, adequate hydration of the patient is very important in all zero contrast interventions. The take-home message is that minimal contrast PCI with the aid of IVUS imaging has significantly reduced the contrast, the incidence of contrast-induced nephropathy. And however, there are some pitfalls of IVUS. Is that how do we position the stents in an ostial location? This can be done by using an 8 French guiding catheter and having IVUS in the side branch. And we can have a wire as a marker in the side branch, or you can use a calcium, fluoroscopically visible calcium as a marker. And some of the things that we cannot detect with IVUS is a distal flow or a side branch occlusion, or a distal vessel perforation. And that is exactly why we do a final injection, which will not only help us see the optimal result also, but we can also identify if there's any slow flow or an impaired distal runoff. And most importantly, we can rule out a perforation. So therefore, to conclude, ultra-low contrast PCI is a feasible and doable option with intravascular ultrasound imaging guidance. Meticulous planning is required, and fluoroscopy and IVUS integration will help when available. And most of the things like stent sizing, positioning, length, and calcium assessment can be successfully accomplished with IVUS imaging. There are some situations such as ostial positioning, which can be a challenge, and there are ways to overcome this challenge. And the final shoot with a very little amount of contrast is required to detect flow, disturbances, and distal wide perforation. Thank you very much.